right. Hi, everyone. Welcome to our 26th virtual shadowing session. Tonight, we will be covering a specialty spotlight in emergency medicine.
Next slide.
All right, so here are upcoming sessions. On December 1st, we have a PA spotlight in gastroenterology. On December 8th, we have a path to being a nurse. On December 15th, we have specialty spotlight in physical medicine and rehabilitation. And on December 22nd, we have burnout in medicine. Just a friendly reminder, if you have any questions, put it in the chat as we go along. We will have 2 Q&A sessions, one in the middle and one at the end. All right, so here's our virtual shadowing working group. We have Reagan, Cheyenne, Taylor, Rachel, Ani, Rohit, Miriam, and myself. And then we also have Dr. Ray Fowler, Dr. Marchetti, and Dr. Salazar. And with this being said, Dr. Salazar has a few announcements. So Dr. Salazar, take it away.
Hey guys, everybody. Hello, hello, hello. I have 2 big announcements for you. The very first one, hola mi linda gente, todos los que hablan español, gusto de verlos todos. I'm very excited to a special hello to all our Spanish-speaking students tonight. I'm going to be doing one of my lectures tomorrow. It's actually going to be in Spanish. Some of you attended my 5 challenges and 5 lessons learned, but this time I'm going to do it in Spanish tomorrow. So check out my IG. Thanks to AMSA is going to be sponsoring me. So looking forward to having you there. And then for the next announcement, I have a really big item for you. So I have decided to have a little bit of fun. We're actually going to make the first pilot session free of charge for about 500 of you, okay? So next week, I want you to stay tuned, and there are some rules, all right? In order for you to be entered into the contest to attend the live session, you gotta be following me, okay? And I put my IG right there for you. We're gonna be giving away some scholarships to attend the program, and we're gonna be giving away some meet and greets. So that's coming after Thanksgiving, big news for you, and we're almost there. So looking forward to having you.
Just a friendly reminder, there will be an assessment after this session and it will be posted at the very end. All right, Dr. Fowler, would you like to take it away?
Are the slides frozen, Reagan, or what's going on? Or next slide.
I think they're a little frozen. Let me reshare them. I'm sorry.
Well, while you're doing that, let me get started and start picking on Walt Green. This is our 26th session, folks. Virtual shadowing has become a really institution for the US and beyond, which we didn't expect almost 10 months ago when we started, but we've had some extraordinary people who've spoken on these sessions. You can just leave it there for the moment, Reagan, if you like. Maybe you can make it a little larger. And we've covered a tremendous number of issues for medicine, from the business aspects, from oh my goodness, from SWOT, disaster, the life of a medical student, the application process, residency, and so forth. Tonight we have an extraordinary night. One of the benefits of being an old man, which I am, is that I've been around in medicine a long, long time. And I have settled into Texas now for the second half of my career, where in working at UT Southwestern and at Parkland Hospital that you see here, I get to work with some absolutely extraordinary people who are there because they're in the busiest emergency department in the United States. They're there because they love people, they are great doctors, and they love to communicate what they know to the students. Tonight, we have such a person. Walt Green is one of my best friends in the world. He's a little brother I wish I had. Salazar is the son I wish I had. And Walt is an extraordinary clinician who is just a marvelous, loving person who is so experienced in medicine, both from the business aspects as well as from some elements that he's going to talk about tonight that are so special that we'll let him introduce them. So Walt Green, welcome to Virtual Shadowing. You've got 750 of your closest friends sitting here waiting with bated breath swing on every word. So Walt, take it away.
Thanks, Ray. And Gil, good to see you. It's hard to express to most of you because this is all virtual. It really is a pleasure to work with people like Ray Fowler and Gil Salazar, Brandon Morchetti. Brandon came to us as a newly minted medical student and went through our residency. And it's really odd to, have medical students join your program, and you realize with medical students, a lot of them know things that you don't know as a professor. So I'm sure you experienced that a little bit in undergrad. Sometimes it's like, gee, I think I know more about this than my actual professor knows. Well, that's definitely true in residency. And then these guys are and gals are just so brilliant that they kind of streak ahead of us. So it's just been a pleasure working at UT Southwest. This is a picture from just my iPhone walking into the department one day. I looked up and thought, hey, that's, a pretty nice shot of nice blue Texas sky reflecting off Parkland. I think a fair number of you know a little bit about Parkland. Some of you know nothing about Parkland. But we see about 250,000 people walk through the doors of that building every year seeking emergency medical care. And in our main ED, we see about 140,000 of them. We bleed about 65,000 off to an urgent care. And then the remainder of that, another 40 or 50,000 are divided up between a psychiatric emergency department and an obstetric gynecologic emergency department. So that's a lot of people, 250,000 coming through an emergency department. Most EDs are about 20 to 50,000 visits. So, the average ED were more than 5 times the size. So it's a very big place. We can go to the next slide. Very big place. And the thing to remember about emergency medicine is it's organization from utter chaos. So I think most people have seen examples of emergency departments either on TV or movie or some dramatic presentation. And in general, it's a very organized group of healthcare individuals, people like Ray Fowler and Gil, who were not running around screaming and yelling things. It's very organized, and it starts out front with receptionists and nurses who appropriately triage the patient. And they decide, gee, this patient is really sick and they need to come back, or EMS may call us and tell us this patient is extremely sick and we're coming in with somebody who needs to be seen immediately. Or it may just be a person who's upset with their family. It's a situational problem. And so they're really not that acute. So they're divided up from the severely acute all the way down to, hey, maybe this really isn't that big a deal. And there's a wide mix. So we really organize in emergency medicine from chaos so that it's all well developed and the patients are appropriately triaged. So what Ray and Gil and Brandon and I teach all our residents is when you enter a room to see a patient, the first thing you do is you stop and you say, what do I hear? What do I see? What do I smell? That's the very first thing you do. And we're going to do a virtual emergency department visit tonight. We're going to go in several different patients' rooms, and that's how you're going to start off with every single one of them. Is like, what do you see? What do you hear? What do you smell? And then the first thing we really focus on as physicians is airway, breathing, and circulation. So every single patient, when I enter the room, it's like, first thing I want to know is, hey, is this person breathing? What's their airway like? Have they got a burn in their mouth? Have they choked on something? Are they able to take a breath? And then do they have a pulse? Is their circulation functioning? Do they have a blood pressure? And that's how we proceed. So we're going to kind of look at some of these different cases, and that's always going to be, hey, how do you approach this patient? Don't get sidetracked. Start off with the basics. We can go to the next slide. So remember these things. We're going to get going. I want you to just kind of think, I'm actually showed up in the emergency department and I'm hanging out with Fowler, or I'm hanging out with Salazar, I'm hanging out with Green or Morchetti, and we're going to go from room to room and see some of the cases that I've seen over the past almost 30 years now. Next slide, please. So here's patient number one. The patient is in a room and you actually get called by EMS before this patient shows up. And the patient shows up in one of our major resuscitation rooms because he was out riding a motorcycle, maybe like this guy I pulled off the internet. You can see the guy doesn't have a helmet on. He doesn't have protective gear on. He doesn't have good shoes on with steel toes like any good motorcyclist should know to wear, but obviously they don't a lot of times. So this patient comes in and I might send you in the room, but this is a trauma patient, a major resuscitation. So I'm actually going to walk in there with the resident and with the medical student. So what's the first thing you want to do? You want to look at this patient and say, hey, what do I see? What do I hear? If this patient is screaming at me saying, Doc, my right ankle is killing me, then you know immediately the airway's okay. The guy is breathing okay. He's probably got decent circulation, right? Because he's yelling at you and he's griping about his ankle. As opposed to if we walk into this room and we see that ankle and the patient's laying back looking at the ceiling, not complaining, not yelling, not making any sounds, that's a very bad sign. So remember your ABCs, airway, breathing, circulation. It's easy in trauma to get distracted. So when I send a resident in that room, you look at this ankle and you're like, man, that thing looks bad. I mean, he's standing at home plate and his right ankle's pointing down the third baseline. So there's something wrong with the ankle. You forget about the ankle and you go right up there to the airway. And it's like, hey, dude, are you okay? And at that point, he starts telling you my ankle is killing me. But we still have to do the airway, breathing, circulation. So anybody have any idea what's wrong with that ankle? So let's look at the next slide. So this is an X-ray of this poor guy's ankle, and this is a fracture dislocation. So not only are the bones broken, but they're no longer aligned where they're supposed to be. And looking at that X-ray on the right, you learn when you look at X-rays, you don't hang the X-ray up like you're looking at the patient from the back. You hang the X-ray up like you're looking at them from the front. So the patient's right lateral ankle, the outside of his ankle, is over there on the left side of the X-ray. So it's just like we're looking at that ankle. So you can tell there's something really bad wrong with that ankle. And our duty is to try to fix this poor guy's ankle. So we put an IV in this poor guy. We give him drugs through the IV to control his pain and sedate him. And then our duty as the emergency physician is to make sure this patient gets good procedural sedation while our orthopedist pulls on this ankle to get it back in shape. Now, if you look at that ankle real good, for those of you that know any anatomy, the tibia is that big bone up top on the right. The fibula is that little nice thin bone up top on the left. And there's a bone underneath it called the talus. And that is the worst looking talus I've seen in my entire career. It's rotated at least 90 degrees, more like 120 degrees. I didn't even know you could do that to a talus. So this is like not only a dislocation, but a grossly displaced talus. Next X-ray. So that X-ray on the right is what it looks like after we gave him sedation. The orthopedist pulled on it and we got it lined back up. So you can tell that looks a lot better than it did way over there on the left. This poor gentleman had to go to surgery because those bones will not stay in their proper alignment. So he had to go to the operating room and get plates and screws and all of those fragments to hold it in place. A lot of his tarsal bones down in the ankle also had fractures, the talus, the calcaneus, some of the other bones. So this poor guy's ankle is just an absolute mess. Ray or Gil, do either of you guys ride motorcycles?
I just put mine up for sale after I saw this x-ray.
No, sir, not for me. Thank you so much.
Yeah, so the joke among any emergency physician who has children, if my children meet up with some other group of kids and some of them, their parents are emergency physicians, they all huddle together and say, you guys can't ride a motorcycle, can you? Nope, my dad won't let me. My mom won't let me. You guys don't have a trampoline, do you? Nope, you don't have a trampoline. No trampoline, it's amazing. It's like there's certain things that most emergency physicians won't let their kids do because we see such disasters in the emergency department. And, it's like I rode a motorcycle when I was in college, and they are a lot of fun. And after working in the emergency department and seeing so many poor cyclists run over, it's like, yeah, not doing that. All right.
Well, we used to call them murder cycles back in the old days. Maybe we don't anymore.
Yeah, well, and we still call them, in my family, we see somebody riding a motorcycle with no helmet. That's called a donor sickle. So they're probably going to wind up brain dead and have to donate their organs. So we call that a donor sickle in my family. So this is an interesting case. Just his only complaint was a 35-year-old gentleman. He complains of shortness of breath. That's a little bothersome complaint to an emergency physician. Most docs don't like that complaint because it can be really a sign of some bad problems. So this gentleman was in a room. Hey, you're a med student. I send you down there. First thing I want you to do when you enter that room is, hey, what's this guy look like? What do I see? What do I hear? What do I smell? Anything weird going on? And he's sitting up in bed, smiling, watching TV, drinking a Coke. But his complaint is shortness of breath. So there again, first thing we do is the good old ABCs, right? Airway, breathing, circulation. He's talking fine. He breathes fine. His pulses are good. I look up at the monitor up on the wall. His blood pressure's okay. We have one of those little things you put on your finger called a pulse ox. He's oxygenating well. So all that looks pretty good, except we kind of notice the oxygenation, which normally should be about 98%. So if you're really freaking out and you go in an emergency department, you're upset about anything, your pulse ox may actually be 100%. You're breathing so fast. Most of y'all are super healthy. So if I get you to hyperventilate, you're going to be up at 100% oxygenation, which 98% is really about normal. Well, this poor guy is sitting there comfortably in bed, but his is about 92%. So not bad, but also at 35, he should easily be 96, 97, 98%. So this was a very nice man, and he talked about his two older brothers always made fun of him and called him E.T. because he had fingers like the extraterrestrial, the old movie. And he said, man, you put me in a dark room with a laser pointer, I can do some great tricks with these fingers. But he'd had this problem since being a teenager. And this is called, if anybody knows what this is, clubbing, very common in COPD, what most of us know as emphysema. We don't see a lot of that in Texas. You see a lot more of it in the tobacco belt up in North Carolina, Virginia, Kentucky, especially in older people. We used to see it in a ton of veterans. But this is clubbing. So the nail itself is swollen at the base. And you can see that the distal finger, the tips of the fingers are bigger than they should be. And the angle there at the nail bed, right where the nail forms, is a very odd angle. And so that's called clubbing. And you see it with chronic hypoxia, low oxygenation. And it turned out that this guy wasn't a smoker. His chest x-ray, his lungs look fine. We wound up admitting him to the hospital because we couldn't figure out why he had clubbing, why he was short of breath. And he wound up having a heart cath. And it turned out that one of the big vessels that came down from his head, one of his major veins, his internal jugular that meets up with the subclavian on the left side, went directly into his left atrium and completely bypassed the heart. So he was dumping probably about 20% of his blood supply unoxygenated back into his bloodstream to be pumped out by the left atrium, left ventricle. So he had an anomalous blood return is basically what caused this chronic hypoxia. His heart otherwise was okay. And the last I heard, the surgeons all looked at him and said, you know, really not much we can do for that. The surgery is probably riskier than just leaving him alone. So the decision was, look, his oxygenation is a little bit low, but we're just going to let that slide. And as far as the cardiothoracic surgeons were concerned, no surgical treatment. All right, next slide. So maybe you guys come shadow with me on a Saturday morning, and we're sitting in an emergency department in Kentucky where I used to practice for 26 years. And we're sitting in the emergency department. Well, in walks the hospital chaplain. So while we're sitting there, we're both bored to tears this Saturday morning. There are no patients, nobody to be seen. Just one or two patients came in with some kind of vague complaints. We've worked them up, and we're playing on the computer, and you pull up the Cyrillic alphabet. So you pull up the Cyrillic alphabet, and we're sitting there looking at these Cyrillic letters like, man, I don't know what these are. Some of these things look familiar, and some of them I got no clue. At which point the chaplain walks over and goes, hey, Green, do you and your student there, do you and Wynn, do you guys know how to read Cyrillic? Do you guys know how to read Russian? It's like, no. He's like, well, I just got a call from a church in Russia, in Moscow, and they want an ophthalmologist to come. Do you know any of the ophthalmologists here? It's like, yeah, I know all three of them. So he gives me this task of, will you ask the ophthalmologist if they'll go to Russia? Sure. So I wind up that day, since I didn't have anything to do the next couple of hours, I track down all three of these ophthalmologists. It's like, hey, the Russians, this is 1993. The Russians in Moscow at a huge church need an ophthalmologist. They need a clinic. And so can any of you three folks go? Well, two of them were too chicken to go. And one of them was like, I got a new practice. Like, no way I can afford to do that. So I get back with the chaplain a couple of days later. It's like, yeah, I talked to all three of them. They all, you know, they can't do it. Sorry, I can't help you. So he looks at me and says, hey, you and the medical student want to go? You and the college student want to go? And it's like, sure. What are we talking about? So he's like, you got to go for 2 weeks and you'll run a clinic in the church and try to help these people. So it's like, okay, sounds good to me. So next slide. So, you know, it sounds like really complicated going to Russia. For me, it was like super easy. It was like, here the communist system is completely collapsed in 91, 92 in Russia. And here in 93, they're struggling to keep their citizens in decent health. And so one of the churches right there near the Kremlin, Central Baptist Church, says, hey, you know, will you guys come help us? So I showed up with 3 other docs. We wound up seeing about 900 patients in 2 weeks. And we took in probably $250,000 worth of medication to basically give to the patients there. And they came in to our little clinic we had set up, which was actually in a wing of the church. None of them were dire emergencies, but a lot of them were the very typical things we'll see in the emergency department. And so we just treated them. The other 2 docs turned out to be family practitioners, and I was the only emergency physician there. But our practices are somewhat similar at times. So they would send all the sickest patients to me. Next slide. So this was one of the patients we saw. And it's a 45-year-old Russian lady whose chief complaint was, you know, I'm itching. I'm going crazy. I started this morning after eating breakfast, and I'm just, I'm going crazy with this rash and I'm itching. So, we go in the room and it's the same basics, right? What do we see? What do we smell? What do we hear? Well, she's talking okay. We're having to use a translator, obviously, and she's talking okay. And this is very similar to a patient you'd see in anywhere in the United States. It's like they come into the emergency department because some acute allergic reaction and they don't know what it is. So yeah, somebody's posted urticaria, and that's a great description of this. So one of the things you teach your residents about rashes is when you look at a rash like this, there's redness and there's swelling. And if you feel the skin, there are little bumps. So if it's a flat discolored area, it's called a macule. If it's a raised discolored area, it's called a papule. If it's a big raised discolored area, it's called a plaque. So this is plaques when they're red and they itch, especially down there at her right hip along the iliac crest, down near the pelvis. You can see it's raised. And those are very classic for urticarial patches. So anybody have any ideas what causes this? So I think somebody posted liver disease. There are a lot of things that can cause it, but most commonly what Gil and Ray and I see and Brandon Morchetti is this is an allergy to something. And so one of the things we do is make sure, first of all, that airway's okay. They haven't closed off their airway from severe swelling. They can get pretty wicked swelling in the airway. It can even kill them. It can drop their blood pressure to 0 and they can have a stroke, basically have an arrhythmia, abnormal heartbeat, and die from this if they're in really bad shape. But most of them actually do okay. They're just miserable. So they just need symptomatic treatment. It turned out this lady had taken some medication that morning because she had a headache, and she took aspirin, and she hadn't taken aspirin in years, and she probably had an aspirin allergy and simply didn't know it. The problem with the Russian medications back in the 90s is they were all contaminated. And so all of the Russian citizens were desperate, whether it was getting medication from India or Iran or the United States or somewhere in Germany. They felt like those medications were fairly pure, but the Russian medications that the communist government had manufactured were very unreliable, contaminated with a lot of different things. And so it was like, we think this is an allergy to aspirin, but we're not really sure what the medicine you took might have had in it. So we basically had to send her out on just some simple medications like a steroid for the inflammation, oral steroid pills, and then Benadryl to try to relieve the itching. And she did fine, and she knew to avoid the medication after that. But of course, I'm sure plenty of people online have seen this either in a family member or even in yourself if you've got a bad food allergy. There's certain foods patients can eat and they will develop the same thing. All right, next slide. So the interesting thing to remember about patients, when you get to do global health, you get a really good idea that no matter where you go on the planet, all the patients are the same. I would have little ladies come in and the translators would apologize profusely like, "Doc, I am so sorry. I don't think there's anything wrong with this lady. She can't land on any complaint. She just wants to talk to you and tell her how bad her life has been." And they were so apologetic. And it was like, yeah, we see this in the United States too. It's okay. And they're like, really? You have people in the United States come in with like these 1,000 complaints and none of them are serious? And it's like, yes, we have that too. And so it's interesting when you do global health, it doesn't matter if you're in India, Iran, Russia, Germany, the United States, South Africa, the patients are all the same. The prevalence of the disease can be very different, but the patients are all still the same. We all have the same fears. We all have the same shortcomings. People make the same dumb mistakes in every country you go to. So it's somewhat refreshing when you get to do global health to see the similarities and kind of the sad state humanity can put themselves in. So it is useful. So we're going to go back to the USA. We spent 2 weeks in Russia, so we go back to the USA. This is the backside of Parkland. The other photo earlier was the front. This is the back, and this is where our business comes in from EMS. So this is a first responder who showed up. The fire truck was called to a scene, and EMS, the paramedics, showed up. You can see the ambulance backed in over the top of those 2 police cars. And so this is a patient who arrives with chest compressions, CPR in progress. So next slide. So here we are doing CPR in a room, and it's a very controlled environment because we're set up to do this. So this is one of our major resuscitation rooms. And interestingly, remember about CPR. Hopefully a lot of you know how to do basic CPR, BLS, basic life support. If you don't, I would strongly recommend every one of you learn how to do that. I know a lot of Boy Scouts get training. Some pre-med programs are good about training their students. A lot of colleges do not. But this is something very useful to know, and you learn it in medical school, and a fair number of medical schools now progress on and teach advanced cardiac life support as well. But here are patients getting CPR. So you can do chest compressions either with a trained healthcare provider, or in this case, we're using a Lucas device. So that's actually a battery-powered device on the patient's chest, which is doing the compressions. And the nice thing about a Lucas device, they can be a little difficult to get. An EMT or your nurses are well trained in this, or your techs, they can get it on pretty quick. And it can provide very good compressions, and it doesn't tire out. For the few of you that have ever done CPR on another human being, it is exhausting after a minute or two, and you have to trade off. But the machine can do a very good job for quite a while. If you look up at that monitor, you might be able to make out that the heart rate is 125. That's actually the Lucas device. This patient did not have any pulses. So we approach this patient the same way we approach all the other ones. When you walk in the room, do you smell anything funny? Like, was this patient in a house fire? Is that why you had a cardiac arrest? Or do I smell anything weird? Do I see burns on the patient? Is there anything odd that I notice on this patient when I first show up and they're getting CPR? And then, of course, we focus immediately on the good old 3s, right? The ABCs: airway, breathing, circulation. So we have somebody get on the chest right away, keep giving compressions while we then give oxygen to the patient and try to get a controlled airway, which sometimes is an intubation. Sometimes the paramedics have already done that for us. In this case, we were able to resuscitate the patient. But if you look at the room here, we've got a nurse who is doing nothing but checking the pulse up in the carotid. We've got a nurse here on the right sitting in a chair. She's doing nothing but documenting. Then we have another nurse there in the blue right in front of her, who is basically getting the medications that the physician is ordering. The physician is the red-headed doc there, and she's basically running this code. She's about to graduate at this point, and I let her just take control of the entire room. I stood back in the corner as the attending. It's like, this is your patient, this is your job, you run the show. And she did a great job, got the patient resuscitated, and the patient went up to the CCU later. This was all cardiac disease. That's what caused this patient's sudden cardiac arrest. All right, next slide. So here's a patient that shows up, a fall from a horse. Now, there's probably not enough right here to get you oriented, but that's a picture of the patient's thigh. His head is up to the left, his knee is on the right, and this is just a picture of the thigh. So you walk into the room and you do the same old thing you do with all of them, right? The ABCs. He's talking fine. He came in on crutches. He's breathing good. His pulses are good. His blood pressure's okay. His pulse ox is fine. But he tells you, you know, doc, this right leg, man, it's killing me. I was riding a horse. We were probably going 15 miles an hour. He was kind of at a pretty good canter, slow gait, and I dumped off and I hurt my leg. It is absolutely killing me, and it turned black and blue. And if you look right over where it says 27 in the line down there, there's a little swollen area there, and that's not his bone. That's a big hematoma. So that's a big collection of blood underneath the skin. And so we have to check that hip joint, x-ray the femur, the hip, the femur, the knee, the lower leg was fine. All the pulses were good. Sensation, muscular function was all okay. But this thing just looks terrible. So we actually got a CAT scan of the leg. So we sent him to the CT scanner, and he had a very unusual finding. It's called internal degloving. And that's where the tissue inside literally tears apart, and the muscles, which are normally bound by different fascia planes, had all torn apart. And so he had bleeding from that. And this is called a Morel Lavallae. That's a term described back in the 1800s about internal degloving. And we can now see it on CAT scans. Sometimes these are large enough, they actually need to be drained. So I had to have the surgical team come see this fella, and they had to make a decision whether to go in and drain it or just let it reabsorb. And the decision was with him, just let it reabsorb. Again, the risk of going in there with him was probably greater than leaving it alone. We all know if you leave it alone, it's going to remain sterile. If you start cutting open or sticking needles in it, you may introduce some bacteria in there, like good old Staph aureus or Streptococcus. So decision was made just to leave this alone. But a really interesting case from just good old fall from a horse. Next slide, please. So one of the things we do at our program is we don't like our residents just training in Dallas. Obviously, in the United States, we have great health care. And great health care can mean a lot of different things. And depending on where you go in the world, you get to see different systems. And I think one of the beauties of the US system and the United States in general is we're continually taking things from other countries that work well there. We bring them to our country to improve our own situation. And that's been since the inception of this country, how things have been done. So one of the things we like to do is get our residents out of our system, and we send them down to New Zealand, which is there in the bottom right. If you look at the upper island, the North Island, there's a bay there on the right side, and that's Hawke's Bay. And that's where we send our residents when they're in their third year. They can go for an 8-week elective over there. Out of 22 residents, we're able to send about 18 or 19. So they get to experience New Zealand. As you can imagine, during the pandemic, our residents are very unhappy because they don't get to go to New Zealand. And so as many of you experienced a senior year in college, or you may be college now, and it's like, this really is not what I was expecting college to be like. Well, it's the same in residency. It's the same in the emergency department. They were expecting to be able to go to New Zealand, and they didn't get to go. So, and we don't know when New Zealand is going to open back up, but we send them to New Zealand. And again, it's global health. They get to see different prevalence of disease, but still patients do the same crazy things they do in the United States. Next slide. So this next slide is a picture of a patient from New Zealand. Can we advance the slide? Next slide. There we go. Great. So this is a 50-year-old, and New Zealanders get around oftentimes by bicycle. It's a good way to get around the island, as you can imagine. Fuel there is very expensive. Electricity is very expensive. So a lot of people choose to ride a bike. Well, this 50-year-old fell off his bike and came in complaining of pain. So we do the same thing. You know, what do you see? What do you hear? What do you smell when you walk in the room? And the ABCs, right? Airway, breathing, circulation. So yeah, there's something wrong with his right clavicle. So the center of the body is called medial, and the outside of the body at the tip of the shoulder is called lateral. So some of those terms you may know from anatomy, some people may not know those terms, but this is the medial clavicle, his right medial clavicle. When we're looking at him, it's the left, but it's his right. That medial clavicle is grossly deformed. So anybody have any idea what sits right behind the clavicle? So right behind that clavicle are there's some ribs, but there's some very big vessels. There's a very big vessel called the subclavian vein and the subclavian artery. And at the center of that clavicle, the medial aspect, what's behind there? So a lot of big vessels, and of course, the airway. So the trachea is behind there. So fortunately for this gentleman, the clavicle is dislocated from its medial position, and it isn't dislocated toward his trachea behind, but it's dislocated out front anteriorly. Rarely these things will dislocate posteriorly, and you can literally die from that. It'll compress your trachea and you basically smother to death. It's like somebody choking you. So this gentleman fortunately popped forward, and so our resident basically had to reduce this clavicle by pulling on that right arm and moving that shoulder back to get that clavicle to pop back in place, and then place him in a splint that held his shoulders back so that clavicle would basically stabilize. This gentleman probably had to have surgery to stabilize that, because it probably required a wire. That clavicle probably had to be wired to his sternum for stabilization. That's what we would do here in the United States. I'm pretty sure that's what they did in New Zealand, but I don't have good follow-up on this patient to know what the orthopedist there did. But again, just the good old ABCs. Next slide, please. So we're going to go back to the US. So our resident has spent 8 weeks over there doing what we call second world medicine. So first world medicine is England, Germany, United States. Second world medicine is more like New Zealand. They've got some limited resources, but they still have very good resources, and they are financially very well set there. So we'll go back to the US. This is actually the proverbial bus pulling up at the back door of our emergency department. There were 36 patients on that bus. Fortunately, this was just a drill. So they did a live drill and had 36 people involved in an airplane crash over at Love Field. That's about 2 miles from our hospital. So they simulated a crash, and then they brought patients, and we have to let the residents and the faculty practice on triaging these patients. So that's one of the things we do in the emergency department. The EMS division organizes that. Next slide, please. So here's another case, a 31-year-old male, and he has a history of asthma. So our nurse calls us in the room. It's like, hey, doc, I need you in room L2. That's one of our major resuscitation rooms. This poor fella has asthma. He's complaining of shortness of breath. You can see his heart rate up there. The green number on that monitor is 155. His temp is 102.2. We've put a pulse ox on his finger. We're not getting a very good reading. We finally get a reading. It's about 90%. So anything anybody can tell me, when do you think this picture was taken? Was this picture taken 5 years ago? 5 months ago, 5 weeks ago? Any idea? Yeah, exactly. Somebody put up COVID. So this is a COVID patient. So the poor guy's only 31, has a mild case of asthma, uses an albuterol inhaler, and about 6 days ago started feeling bad like he had the flu. And then he came in to see us with a heart rate of 155. So normal heart rate for a 31-year-old should be probably about 72 or 80, right? Not 155. So this poor fella is really sick. This is a bad sign when your heart rate is that fast. Every resident in our emergency department knows one thing, and that is you never send a patient home with a rapid heart rate that's basically over about 100 or 105, unexplained tachycardia, because we have one professor that browbeats that into all of us, which is very helpful when you have a colleague like that who knows his stuff. And that guy's name is Ray Fowler. So Ray Fowler is always telling us and the residents, if you don't know why their heart rate is fast, if you don't know, don't send them home, because they're not going to do well. And this
Well, it seems, it seems simple, Walt, but it's not. It's
right.
Because that's why they call them the vital signs. And sometimes, we kind of, my old pappy used to say, people look, but they don't see. And that's, your first slide of what do you see, what do you hear, what do you smell? You have to start very basic to determine, is this patient having an emergency?
Yeah, and this poor guy really didn't have much wheezing. So I was hoping he's just having a flare up of his asthma. He's got some virus, and we'll be able to fix him without too much problem. We gave him several albuterol treatments. And of course, he got a chest x-ray. He wound up getting a CAT scan of his lungs, and he had pretty bad COVID infection. We offered him remdesivir, which is one of the IV antivirals for very sick patients with COVID. His admitting team, his ICU admitting team, talked to him about, hey, do you want to take remdesivir? It may help, it may not. It's got some risks with it. It's not a perfect drug. He elected that night not to take remdesivir. He's like, I don't think I want to do that. Let's just treat my asthma. Let's treat the COVID. Let's see, how we do. So 24 hours later, this poor fellow was dead. He did not respond to treatment. He continued to get worse. About 5 hours after we got him up to ICU, he had to be ventilated because we couldn't keep his oxygen level up with multiple methods. And he wound up going on a ventilator, and then his lungs just filled up with fluid and gunk. And that was the end of that. So unfortunately, this is one of the things we see right now with COVID. It's not just old people. A lot of old people do succumb to it, but young folks are dying from it too. Just sad stuff. Next slide, please. So one of the things we also teach our residents is, when you hear hoofbeats, you think about horses, you don't think about zebras. Unfortunately, in the emergency department, we got to think about zebras too, which means this is probably COVID, but we also have to make sure it's not just a regular pneumonia. Make sure it's not Legionnaire's disease, which is an atypical pneumonia. Make sure that he doesn't have a heart problem that's filling his lungs up with fluid. So this patient got a pretty big workup in the emergency department, even though we were pretty sure at the very onset it was just COVID. His rapid COVID test did come back positive, but we also look for other things like clots in the lungs, heart disease, and then other infectious processes as well. So in this case, it was like, well, we heard hoofbeats. We thought it was probably a horse being COVID, which we thought it was, and it turned out that's exactly what it was. Next slide, please. So you get called by the nurse, you get out of that room, and you hadn't been out for 10 minutes. You've got that patient up the ICU, and the nurse comes in and says, Doc, we had somebody just drive into triage. They've been stabbed. Can you get into bed 2 and see this guy with the stabbing? So, you know, how are we going to approach that? And you approach it like you approach everybody else. You walk in the room and it's like, what do you see? I see a knife blade sticking out of the side of this guy's skull, just a little bit in front of his ear. And it's like there's blood all down his face. And when I look at him, it's like, well, do I hear anything? It's like, sir, can you tell me your name? He's like, yeah, my name's Bill. I was totally shocked. It's like, this guy can talk with a knife in his skull. And he was able to talk, move everything. We went through the airway, breathing, circulation. You know, remember, we don't just submit to chaos. We do it with an organizational plan. So we made sure his airway was okay. The concern to whether it's Dr. Salazar or Fowler or myself is, where's the other end of that knife? Is the tip of that knife down in his airway, like at the back of his throat? And is he developing a hematoma in the posterior pharynx that's going to swell up and block off his airway and kill him? So, you know, we immediately look in the airway. Nope, no blood in the nose, no blood in the mouth, looks perfect. He can talk. Any change in your voice, sir? Are you hoarse? Nope. Airway's fine, breathing's fine, blood pressure's great, heart rate's like 95. So just absolutely shocked, you know, it's like, wow. Turns out he made a girlfriend mad. So his girlfriend stabbed him with a steak knife. And I'll just tell you, this must have been a pretty big gal, because I can't imagine having enough strength to drive a steak knife through somebody's skull. But not only did she drive it through his skull, when she jerked it back, she jerked the handle off of the knife. And bone, when you put a piece of metal through bone, it really grabs it. You would think bone is brittle, but that's because we see skeletons. Bone is very much alive, has quite a bit of elasticity to it, even though it's stiff, it's not brittle. And if you put a nail or a knife through bone, it really grabs a hold of it. So this poor gentleman, I had to call the neurosurgeons. We CAT scanned him. The knife blade was in his brain, and he didn't have very much bleeding around it. The neurosurgeon had to get his partner. So they basically, 2 neurosurgeons went to the operating room with the plan of pulling this knife out. And if he bled on the right side of his brain, which would cause weakness in his left arm and left leg, then they would have to basically take the top of his skull off on the right side and stop the bleeding emergently. The tip of this knife went to the circle of Willis, which is where the internal carotids join inside the skull. And if that started bleeding, the approach is through the mouth. So one surgeon was prepped to take off the top of his skull. The other neurosurgeon was prepped to enter through his mouth. And when they pulled the knife out, all they used initially was a local, because they wanted him to actually be able to function, to figure out, hey, is the bleeding acute in the brain? What's going on? So they wound up pulling this knife out in the operating room with the anesthesiologist ready to intubate him, the neurosurgeon at the top ready to cut off the top of his head, the neurosurgeon at the left side of the bed ready to go through his mouth. Turns out nothing happened. He didn't have any significant bleeding from it. They kept him in there over an hour and a half. He did great. They sewed him up. They kept him in the hospital for 2 days, got several more CAT scans. No problem. Wound up going home. I talked to the guy on the phone about a week later, and he was doing okay. No longer seeing the same girlfriend, but he was doing okay.
Did you give him a couple of days off work, Walt?
Yeah. So, you know, just amazing. I mean, you know, Dr. Fowler and Dr. Salazar can both tell you that this totally unexpected. I figured this guy was dead from the onset, and somehow he got out of the ER pretty much unscathed, left the hospital with just a tale to tell. That was about it.
That's also that's the thinnest bone in the body right there.
Hey, Walton, one thing to remember is this couple may have been very well in a bad domestic situation. So he may be injured and make it, but maybe the next time around, it might be his girlfriend who comes in worse shape or dead. So there's always that story behind everything. God only knows what was going on at their home.
Yeah, unfortunately, we do deal with a lot of domestic violence. Next slide, please. And so somebody says, how do you deal with this legally? The police come in with all of these people, and if they're not already there, we call them for shootings and stabbings, and then they have to investigate the scene. Unfortunately, sometimes the violence actually comes to the emergency department, so that can be a little exciting when it actually shows up at your hospital and they're still fighting. But fortunately, we have a great police force in Dallas at the hospital. That is not the case at all hospitals. I've worked at several hospitals where we had no police force, no security, nobody on campus was armed, and it can be pretty frightening at times. So here's another room we walk into, send you down the hall. It's like, hey, go down the hall. There's a 20-year-old down there who's pregnant, and she's got itching, some kind of rash and itching. So most women in this state of pregnancy, she's about 36 weeks pregnant. So full term is 40 weeks for those of you that don't know it. 36 weeks pregnant. And they normally go up to labor and delivery. However, if they have a rash, the worst place to send them is labor and delivery. Because what if this is measles? So measles is much more infective than COVID even. It's a wicked, wicked virus. And if you make the mistake of sending a poor lady with measles up to a labor and delivery suite, then she can infect all the other pregnant women up there and all the newborn babies who are not quite immune yet. So it can be a real problem. So pregnant women with a rash oftentimes wind up in our emergency department for us to evaluate. So her complaint was, just maybe about a week ago, I started having some itching. We call that pyritis. She started having itching on her abdominal wall, specifically where her stretch marks were. This is her first pregnancy. We call that gravida 1. So her first pregnancy, and she hasn't delivered yet. So we abbreviate that as a G1P0. P0 meaning she hasn't had a delivery yet. So she's 36 weeks, first pregnancy, itching started at her stretch marks. It's progressed. It's mainly there on her abdominal wall, not really on her legs much, none on her arms, none on her face. And it's symmetric. So if you look at her body, one side looks like the other side. We teach all our residents, always look at the rash and see if it's symmetric, because if the rash is just on one arm, you got to think about contact allergies, right? Or if it's just along the belt line, maybe they're allergic to their nickel-plated belt, which we'll see. So you have to look and see if it's symmetric or asymmetric. Hers is very symmetric, which usually tells us that's something systemic. It's something from within, her whole body is affected. So yeah, is this something as simple as eczema? No, eczema usually is not very symmetric. It's like, I got a patch on my arm, I got a patch on my face, I got a patch on my right calf. So it's not simple, seborrheic dermatitis, it's not eczema, it's not one of those rashes. This is a very specific rash to late pregnancy that most physicians will become familiar with if they see enough pregnant patients. So all the OBs know it. The OBGYN docs all know it. A lot of ED docs and family practitioners know it, but other folks, not so much. So this is called PUPS, P-U-P-P-P-S, which is Pyritic, Urticarial, Plaques, and Papules of pregnancy. That's a mouthful. So basically it means, hey, lady, I'm really sorry. You're in the late stage of your pregnancy. You're already miserable. You're carrying this baby that's ready to come out of you. You're not eating right because you feel bad. Your stomach is compressed. You're having to pee all the time because your bladder is compressed. You can't breathe like you used to be able to breathe because your lung volume's down because of this big baby you're carrying. You're not sleeping well at night. And on top of all of that, now you're itching. It's all the same process. It's because of your pregnancy. So you can treat this with topical meds like a topical steroid. We can give them Benadryl to take by mouth to try to help the itching. The reality is none of that really helps too much. They basically have to deliver the baby. So it just, unfortunately, it's one of these kind of sad things. It's like, we don't know the etiology that's the cause. We don't know the etiology, the cause of this rash yet. Somebody may figure this out during y'all's lifetime. But right now, it's one of these like, we don't really know what causes it. We'll treat it symptomatically. It really doesn't have any other bad effects that we know of. So it doesn't tell us that anything else is going to go wrong or anything bad's going to happen. So we call that just treat it symptomatically. So she went out with a couple of prescriptions, a couple of hugs from the nurses like, sorry you feel so miserable, this will get better. You just got to deliver that baby in a couple more weeks. Next slide. So that's PUPS, P-U-P-P-P-S. About 20% of an emergency physician's practice in a normal emergency department is pediatrics. So I used to see a lot of kids. Right now, we see children who are burned because we have a burn unit, but most of the pediatric patients go across the street to Children's Hospital. We still get some people who make a wrong turn and wind up in our emergency department. But most of the time, not so much. So here's a 13-month-old that I saw who had a fever. She had a swollen cheek on the left side, if you can appreciate that. Her left, our right. And somebody put in mumps. Mumps is a good thought. The problem is this is too far forward. Mumps is the parotid gland, which is just in front of the ear. And you can see back toward the ear, it's really kind of normal back there. So this is just the cheek and it's tender. So this patient came in, wound up getting, IVs, lab, x-rays, everything was normal except the peripheral white blood cell count. So we draw some blood, we send it off for a thing called a CBC, which is a complete blood count, and included in that is the white blood cell count. So the cells that basically fight infection. Normally those white blood cell count, it should be between about 5,000 and 10,000. If you have a bad case of appendicitis, it may go up to 14,000. If you have a really bad case of some other infection, a bad staph infection in your arm or leg, it may go up to 20,000. This poor child's white blood cell count was 35,000. So the white blood cell count was super high. This is an infection we don't see much anymore because of a great thing called immunizations. So this is Haemophilus influenza infection. That's a bacterial infection in the cheek. So that's called buccal cellulitis. So this is an infection in the cheek and cause really bad immune response with that white count of 35,000. The patient was what we call septic and bacteremic. The bacteria have not only localized there in the cheek, but also has gone into the bloodstream. So this patient had to be admitted, IV antibiotics. We can go to the next slide. And the antibiotics work like a charm. This was a couple of days later. You can still see that left cheek's a little bit red, doesn't look like the right. Child did fine, did great. White blood cell count came down to 6,000 the next day. That's how quickly kids can respond. Had the child not gotten antibiotics, probably would have been dead within 24 hours. So there is now immunization that children get for Haemophilus influenza. So Dr. Fowler and I don't see much H flu, Haemophilus influenza, we just call it H flu. We don't see much H flu anymore in kids. We used to see a lot of epiglottitis, buccal cellulitis, and so
meningitis.
Yeah, meningitis too. And that's the beauty of immunizations. They work really well. It has reduced childhood diseases in the United States tremendously. That was a picture from back in the 80s. So back in the 80s and 90s, we saw a lot of it, and now the kids are all immunized. They've got, they invented a good H flu vaccine. We just don't see that much anymore. So you can't speak enough about vaccinations and how much they do for the healthcare of people everywhere, even in the United States. Next slide. So here was a case one of my colleagues turned over to me. He had seen it, his resident had seen it, one of the medical students had seen it, and they were perplexed, like, we don't know what this is. And that's the bad thing about being the old dude. People come get you, and it's like, look, if Gil doesn't know what it is, I probably don't know what it is, but people will come get you. And it's like, hey, I bet Green knows what this is. So they came and got me and said, what do you think this is? So, I take a look at this guy, and he's got, this is a picture of his elbow, kind of his triceps and near his elbow. His knees look like that, both knees, both elbows. And then he had a few of these spots on his back. So each one of them was about 3 to 4 millimeters across. So, not even really a quarter of an inch across. And they were kind of pearly white, a little bit raised. So that would be a papule because it's raised. Remember, macules are flat. But this is a little papular rash of some sort, but it itched a little bit, but he had no other symptoms. Airway, breathing, circulation, all of that was fine. He doesn't have a fever. He doesn't look infected. We checked some lab tests on him. They were already back when they came and got me and turned this patient over to me and said, we were going to let him go home, but, we knew you were coming in. So what do you think? And I looked at this guy, and it was one of those things like, last time I saw anybody like this, they had these underneath their eyes. And they were cholesterol deposits underneath their eyes. So that's called xanthelasma. And I saw it a lot in Mississippi. I had a lot of patients in Mississippi, and they would have these little cholesterol deposits in the skin, these kind of pearly white things underneath their eyes, but I'd never seen it on the elbows or knees. So it's like, well, let me check a lipid panel, a cholesterol, a triglyceride panel on this guy. We normally don't do that in the emergency department. So 8 hours later, after 5 different attempts to run this poor guy's cholesterol and triglyceride, I was talking to one of the pathology residents, and they were like, you know what? When the machine won't read it, it's because it's so crazy high. So we're going to ultracentrifuge the blood. So they took the patient's blood, stuck it in an ultracentrifuge, and a normal cholesterol should be about 120, 130. People whose cholesterol is elevated may be 250 or 300. This guy's cholesterol was 1,500. His triglycerides, which should have been about 200, were 4,000. Next slide, please. So if you let his blood sit on the counter, this is what it looked like. Normal blood, if you let it sit, the red cells will kind of go to the bottom and the serum comes to the top. And the serum looks like ginger ale. It's got a little yellow color to it. For those of you that have drawn blood, you know that if you've worked in a hospital. But I know a lot of you have never actually done phlebotomy. You've never drawn blood, so you don't really know what it looks like. Well, the serum floats to the top after a while. Well, this guy's blood got left in a syringe sitting on the countertop, and that's what it looked like, that buttery looking serum, which is the triglyceride of 4,000 and the cholesterol of 1,500. So this was a clue right out of the gate. Had we actually put the blood up there and watched it, we would have known, hey, this guy's got horrible problems with his triglycerides and his lipids, and he wound up being admitted for that. It's called eruptive xanthoma, and that basically means you get bumps everywhere because your cholesterol and triglycerides are too high. So he was treated, believe it or not, with IV insulin. We used IV insulin to get his blood sugar to drop. When his blood sugar drops, his glucose in his blood comes down. There's an enzyme in the liver that begins working again, and his triglycerides and his cholesterol came down. He got put on several different medications, and those will actually dissolve over a period of about a year and go away. Not quickly, but they will go away. So it was one of those cases where he had no idea he had a cholesterol problem. And it's like, you not only have a cholesterol problem, you have a gold medal Olympic winner problem. Yours is like the worst ever. So this is fairly rare, but it's out there. Next slide, please. So I send you in a room to see a patient, and her complaint is, hey, I got an abscess. So my medical student goes in the room and she complains of this very, very painful abscess. Her head is up to the left, her knee is over to the right. This is kind of at the junction of the buttocks and the thigh. And she's got this very tender 5 centimeter, about a 2-inch area, very tender there, hurts like crazy to touch it. And then she's got these other marks on her thigh. Anybody know what those spots are from? Any ideas? Yeah, bingo, somebody put up drugs, heroin. This is heroin, classic heroin abuser who injects subcutaneously. That's called skin popping. You know, if you inject it directly into a vein, that's called mainlining. Skin popping is easier. You just stick it under the skin. Obviously, your technique is probably not very sterile. The needle may not be very clean. And so here's one of the results. So you get necrosis, which means death of the skin from those old skin pops. And so you get these little scars. And then you may get a staph infection, which is what happened here. This poor lady got a staph infection with an abscess. So my resident had to go in with the medical student, and they used a topical anesthetic and then made an incision with a scalpel blade and drained out probably about 10 or 15 cc's of pus in that abscess, left it open and let that thing heal up, let the abscess.
So hey, Walt, how come she used a skin popping? Why can't she just use a vein?
Well, that's a good question. I think that is that she may have burned out her veins,
Right.
or
She's run out of veins.
yeah, she may have run out of veins. Another curious thing is I've seen in young women who abuse heroin is they want to wear a bikini top at the beach. So they'll wear a pair of blue jean cutoffs where they can hide the skin popping underneath their blue jeans, but they don't inject anything above their waist. So they just inject their hips. And that was, I think, what this girl did, is she just basically skin popped, and she had no track marks on her arms. She just like, I'll just skin pop. That's how I'll get my high. But yeah, you can burn out your veins. I think this was an aesthetic choice by this patient. And of course, my resident had not seen these scars before, had no idea what we were looking at. So I had to kind of say, this is classic heroin abuse. This patient is a heroin addict, and the abscess is from a dirty injection, basically injection of staph. Contaminated the needle or went through the needle track, one or the other.
Walt, you mean that people don't take a lot of time to sterilize their needles and inject? completely sterile heroin?
Yeah, apparently not. Yeah. All right, next slide.
All right, we have quite a few questions. So, one question said, do you see any uncommon vitamin deficiencies in different countries?
We do, but they're a little tough to diagnose in a lot of the situations we're in. So the patients may have joint disease from a vitamin D deficiency, but we don't have a good way to diagnose that. So the answer is oftentimes yes, but we have to do what we call a shotgun approach in a lot of those situations, which is, I'm not sure if this is a vitamin deficiency, but one of the things we actually do in a lot of places we go is every patient we see, we'll give them a 3-month supply of vitamins for free, because we know their diets can be very odd, and it's tough to diagnose that.
Okay. Another question we have is, what motivated you to pursue global health? Was it the right place and the right time kind of thing, or were you motivated by your own intent?
Yeah, it's usually a combination of things. For me, it had to do with my own personal faith. That's why I knew the chaplain at that hospital. He was a Christian chaplain. He knew I was a Christian. The church in Russia was the only Baptist church left open by the communists. And so he knew, hey, Green probably wouldn't mind going, and it would work out fine. And then I wound up involved in some other locations that we'll talk about if we have time. The same way, I had a friend at church who kept trying to get me to go to Honduras. And it's like, what are you going to Honduras for? And I knew the guy for over a year before I figured out he was the vice president of a Christian missionary group. And dumb me, I didn't know. I didn't know what the guy did for work. And he finally convinced me. He's like, yeah, I need you to go down there and be a doctor. It's like, well, stupid me. I should have asked you a year ago, So I think for a lot of people, they do it through their faith. There are a lot of people who honestly won't do global health because for what I think are probably some good reasons. They're scared. There are a lot of fears. We have a saying in global health, and that is TINA, T-I-N-A, this is not America. And you can get in some pretty dicey situations sometimes. And sometimes the governments are not happy that you're there. They don't like Americans, or they don't like you, or you can offend them by posting. Like, I don't post anything on social media when I'm in those countries because I don't want to offend anybody. That's not my purpose. So we kind of go and leave no footprint when we're there.
Okay, well, that's good to know. Here's a question about COVID. So would you recommend COVID patients take treatment even if they are relatively new?
So I guess the question is, when they say treatment, there are a lot of different treatment modalities, and a lot of them don't work. And this is something that Dr. Fowler and Salazar and I talk about almost daily when you're on shift. Like, hey, what are we doing this week? What's working? What do we know? What does the CDC know? What does our research show? So you'll see crazy stuff on the internet, and it'll be like, oh, zinc and Zithromax work. And I think everybody probably remembers the hydroxychloroquine. Hydroxychloroquine is going to work. Well, it might not. And in fact, it's like, yeah, those don't work, despite a lot of even physicians claiming it worked. It's like, no, it really doesn't work. So I think the first thing you have to try to get a grip on when you're a physician is, what is really science? And we call it evidence-based. What is the evidence-based medicine? What really works? And I want to know if it really works, but I am not going to throw a bunch of medication at people hoping I'm picking the right one, because part of the oath and part of our training is first, do no harm. So we figured out that prednisone, steroids, or dexamethasone work only when the patient is really short of breath and really sick. So if I have 100 people with COVID, I give all of them a steroid, dexamethasone, they're actually going to do worse than a group I don't give any to. But I can actually have a third group that'll do better than the other two groups if I just take the sick people when they're really short of breath and they really have a bad lung infection on x-ray or their pulse ox is bad, and I put those people on dexamethasone, those people do better than if they didn't get dexamethasone. And that's because it dampers the immune system. So part of COVID, it turns out, is the immune system going crazy. And if you treat it too soon, you'll have more people die than if you just wait to let patients kind of declare themselves. So it's very complicated. It's not easy. We don't have a lot of good answers at this point. And it's a day-by-day situation, us checking the literature to find out what's working and what's not.
Okay, it sounds like you have to be very precise with everything you do then.
Yeah, and a lot of it, I know that, my colleagues, we all get the patient involved in these decisions because it's not cut and dry. There aren't good answers a lot of times. And like the young 31-year-old with asthma, remdesivir is not a cure-all. It's not a miracle drug by any way. It's got some side effects, and some of them can be pretty bad. So we have to get the patient involved in the decision. And so we use, decision making with the patient and his family, like, how do you guys want to go from here? Here's what our evidence shows. Do you want to try this or not?
Okay. Another question we have is, how does family life work out with this career, especially with all the traveling?
Yeah, so one of the reasons I chose emergency medicine was because of my family. I've only been married once, thank heaven. I've got 3 kids, they're all grown, and I didn't want to be an absentee father, and I couldn't do a lot of global health because of that. The first trip I made to Russia, I went by myself. And then the next 2 trips I went to Russia, I actually took my wife with me, and she wound up being one of our pharmacy techs. She's not a pharmacist, but we employed her as a pharmacy tech. It's like, you got to come, you got to meet these people. They're fantastic human beings. You get to be in Moscow, and the third time we went to St. Petersburg. So for me, emergency medicine turned out to be a great choice. When I am on shift, I am super busy. I don't have time to talk to my family. I don't take phone calls. I don't post social media. I don't check my email. But when I'm off, my time is my own. I'm not on call. So unlike some of the specialties where you're on call and the emergency department may call you in the middle of the night, we don't do that in emergency medicine. So for me, it worked out great. I got all my kids graduated from college, and, one from law school, one from engineering school, one from medical school. And, I felt like my family life was a bigger success than my professional career. And that's what I wanted. I wanted to have a good family life, put it before my job, and it worked out well for me in emergency medicine.
I'm glad to hear it. I'm sure a bunch of other pre-medical students are too. So I will do one more question so we can get back to the session. So we have a lot of PA students in our program. So one of the questions said, what is the role of a PA in an emergency department, and how does it compare to physicians' roles?
Yeah, that totally, I think, depends on the setup of the emergency department. When I was in private practice, we had a fast track. So the really sick patients came into the main ED, and then we had 6 beds over to the side. So if a patient showed up with just a wrist sprain, like I think I sprained my wrist, I think maybe I broke my ankle, and they really didn't look bad, we sent those to our fast track, and our fast track was run 100% by our PA. So we had one PA working over there, and we actually had 2 shifts a day. So we had one PA that started at 10 a.m. and went to 10 p.m. And we had another PA that started at 1 p.m. and went to 1 a.m. So they had 2 of them working there in the afternoon and evening hours. And so they saw all the, sore throat, my ear hurts. I think I got a splinter underneath my nail. I think I sprained my ankle. And that's how we used the PA. Sometimes we would have a really large laceration, and maybe it was like 15 inches long, like a chainsaw injury, where they cut a huge wound into their thigh. And I don't have time as a physician to sit down and sew that up, which may take me literally 45 minutes for that one wound. And I had a PA who was absolutely fantastic at suturing. So it's like, hey, Randy, you want to sew this up? He's like, no problem, doc. And so he would take care of all our big lacerations, for example. So it kind of depends on the ED and how your doc likes to use the PA, but that's how we did it. We use them in the fast track, basically.
Okay.
All right, so we'll keep moving along here. So one of the things I wanted to do for the residency, since I had experience in Russia global health, Honduras global health, was, hey, let's find a place for our residents to practice. And so using some contacts I had from Christian missionaries I knew in Honduras, which got too dangerous to travel to, we wound up deciding, hey, they had some friends in Guatemala. So Kelsey Drake, who's another professor, she actually is a graduate of our program. She got a master's in public health before medical school at Johns Hopkins. So she has an MPH, and then she went to med school. And I grabbed Kelsey and said, hey, help me find a place where we can go with the residents. They get first world medicine at Parkland. They get second world medicine in New Zealand. And we really need them to see what medicine is like in a resource poor environment where you can't do a bunch of lab, you can't do a bunch of x-rays, you can't throw a bunch of medications at them. You can do like one thing. That's all we can do. So we wound up finding a place in Guatemala. So next slide, please. So we found a little hospital in Guatemala in a place called Cabulco, and we've got another slide here in a second. But this was the hospital, and these were 2 residents and 1 fellow. A fellow is a resident graduate who stays another year to specialize, and Liang stayed a year to do ultrasound, and then another year as a global health fellow. She's now at Emory University in Atlanta. But these 3 went with me down to this hospital in this little town, interestingly started by a nurse in 1948 in her apartment. She used a room in her apartment to help treat the villagers. This little village is up in the mountains. 20% of the people still speak a Mayan language. They don't speak Spanish, they speak Mayan. And she wound up going to that town. She got recruited out of Wheaton University in Chicago through a Bible Institute because the Mayan people in this town didn't have a copy of the Bible in their language. So if you can imagine being a woman in 1948 volunteering to go into the heart of Guatemala, up in the hills with another woman and learn the language, the Mayan language, and translate the Bible into their language. That's what she did for 4 years. She happened to be an RN, and when the people in the town figured out that she was an RN, she got done with the Bible translation and then stayed on there for the rest of her life as a nurse and formed first a little clinic and then this hospital. So this hospital literally grew out of her apartment building, her little apartment that she had. Next slide. I can't imagine. Guatemala's bad enough in the hills now. It's pretty rudimentary, great place, but I can't imagine being there in the 40s. No phone. I know all of you have a cell phone. No phone of any kind. No electricity back then in this little town. When the sun went down, it got very dark. This is the inside, and we actually slept in the hospital compound back by that palm tree. There's a little room back there, and that's where all of us slept. Next slide, please. And then behind the hospital up on the hill there is where I took the team. I made every one of our teams like, hey, we're not just going to come here, work ourselves to the bone and go home exhausted. Every day after we got done, we would climb the hill. It's like we're going to go for a walkabout around town, either buy something in a local restaurant, shop for something, or we're going to climb the hill. So we all climbed up the hill. That gives you an idea what Cabulco looks like, a town of about 10,000 people. So it's about a 3,000 foot climb up to the top of that little mountain. So good little hike. Next slide, please. So here was one of the patients we saw in the emergency department there. A 3-year-old boy came in with his grandmother, and the chief complaint was something's wrong with his nose. He's got this pus draining out of his nose. He won't let us touch it, and he feels miserable. So, you know, how do you approach this? Well, remember, like everybody else, is he breathing okay? If he's got a nose problem, how's his airway? When I walk in the room, do I smell anything bad? It's like, yeah, it smells kind of like something's dead in his nose. This is kind of gross. And he's got pus coming out of the nose. So it's like, has he got some bad infection? Well, if any of you have little brothers, sisters, nephews, or nieces, you know, 3-year-olds like to put things in their ears, in their nose, swallow things. So airway, breathing, circulation all looks okay, just something wrong there at the left side of his nose. So he took a look in the left nair, and lo and behold, if you, next slide, lo and behold, he's got something in there. And I put my pen by it so you can see the size of that. Anybody have any idea what that is? Somebody put corn. Close. Not a Lego, not a nut. Keep going. So I'm not a coffee drinker. So stupid me, that's a coffee bean. So stupid me, I've never seen a coffee bean except one that's been cooked and they're brown. Well, this thing is green because he picked it right off of one of the coffee plants and crammed it in his nose. And I kept looking at that going, wow, man, all the fluid around it must have sucked all the caffeine out of it. That must be why it's green. It's like, no, dummy, they're green right off of the plant. So the nurses brought me a bunch of instruments, metal instruments, to try to reach back in and grab this thing and pull it out. And it's like, no, 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 no. I'm not going to reach in a 3-year-old's nose with a metal instrument because he's going to go crazy. And I may wind up cutting his nose and we'll have a horrible bleeding. And remember the old ABCs and first do no harm. So I don't want to reach back in there and grab this thing. So I wound up getting a little rubber catheter that normally goes in a baby's bladder. If you had to put a catheter up into a baby's bladder or an infant's bladder, it's a very small, very thin little Foley catheter, about that long. And it's got a little balloon you can blow up on the end of it. So I just put that little catheter in the boy's nose, blew the balloon up, which would normally hold it in the bladder. But I blew the balloon up and then just pulled the whole thing back out, and that coffee bean shot across the room, and bingo, no nosebleed. He was scared when I put the catheter in his nose. I blew up the balloon. He started crying because he felt the pressure. As soon as the thing shot out of his nose, he sat bolt upright and like jumped in his mom's arms and was happy as a clam. So that's a kind of a unique way to get things out of a nose, but it's a common trick. To use a bladder catheter in the nose and blow that balloon up to get that coffee bean out. Next slide, please. So another child we saw was an 8-year-old girl with a rash on her hands. And the mom brought her in because like something wrong with her hands, they're discolored. And so, you know, it's like, just on her hands, nowhere else. And that is like a macular rash, right? So it's not bumpy, it's not a papular rash, it's flat and discolored in big plaque-like areas. And it's fairly symmetric, and it's like, we call it interdigenous, it's between her fingers. So it's like, what did this child come in contact with? The palms were fine. So the palms are not involved at all, just the backs of the hand. And, it's like, well, interesting. Well, one of the things we always do in global health, we always work with a local doctor, because we're not the great, gringo doctors from the north going down there to teach everybody how smart we are. We realize the docs on site know a lot of things we don't know. So we can teach them, they can teach us. So I went and found the doc. This happened to be in Honduras. I went and found the Honduran doc and said, hey, doc, look at these girls' hands. What in the world? Now, if this was in the United States, I'd say this child got a hold of a walnut. If you've ever picked a black walnut off a tree and messed with it, it will stain your hands permanently. But it's like, there are no walnut trees in the tropics down there. No, that's not it. So I had no idea. It's like, what? And so you went, oh, I know what this is. I don't know how to say it in English. And next slide, please. So this is lime juice. So if you get lime juice on your skin and you get significant ultraviolet exposure, it's called a phytophotodermatitis. And you may even see this in the US if you've got a friend who's drinking a margarita out on the beach and the lime juice drips on them and they sit out there at the beach without sunscreen on and they don't get that lime juice off of them, they're going to have a nice dark trail wherever that lime juice went in a couple of days, and it's going to stay there for about 6 months. So it causes a little bit of change in the skin, and it's not permanent, but it's almost permanent. So it'll definitely change your skin and mess up your pigmentation for quite a while. But this in general, not always, but in general, this will get better and go away. So it's like, oh, okay, this is phytophotodermatitis. So just an interesting case, and a little girl that the local doc was able to jump right on. He goes, yeah, I know exactly what this is. I just don't know how to say it. And so he had to basically tell me in Spanish, it's from the lime tree. It's like, okay, I got it. Next slide, please.
Well, one of our comments said they need to invest in a sippy cup.
Yeah, I don't think I ever saw a sippy cup in Central America anywhere. They're probably in the cities, but definitely not out in the towns. So this was an agricultural worker that I saw, and his chief complaint was pain in his right shoulder. So he says, I've got this thing under my skin. It's about this big, and it's underneath my skin on the shoulder. So he came in with shoulder pain. So, same thing, evaluate this guy. He looks healthy. I don't see anything unusual, don't smell anything unusual. And his airway, his breathing is fine. Blood pressure is all great. Well, one of the things you get talked to in the emergency department sometime is fishing for foreign bodies. So it may be a splinter, it might be a nail, it might be a needle they stepped on. In this guy's case, he had been shot 7 months before with a small gauge handgun, and the bullet had migrated to the surface underneath his right shoulder. Next slide, please. So this thing was underneath the skin, and I spent 20 minutes talking to this fella saying, I do not want to go digging for this thing. I call that a search and destroy mission. You would be surprised how hard it is to localize these things and fish them out. You think you're going to get it, and 2 hours later, you still haven't got it. I don't have X-ray to localize this thing, look at it. I have nothing in this village. But this guy's in his 20s. It's over his right deltoid, up here on his shoulder, right deltoid muscle. Every time he swings his machete, this thing hurts him. And he's like, Doc, please take this thing out. So I did everything I could to disclose to him why I didn't want to take it out. He's like, I got it. It may get infected. I could get an abscess. I can get an infection in my bone. I could lose my arm. I don't care. It's worth the risk. Take it out. So it's like, okay. So we numbed him up. And interestingly, what do you think my translator did when I numbed this up, cut it, and the blood ran down the side of his arm? She passed out. I asked her, "Are you gonna be okay?" "Oh yeah, this is fine. I'm okay with this." So as soon as she saw the blood running down the arm, my translator went to ground. So I had to have another doc come in and treat her while I'm treating this guy's arm. We successfully got it out. That's what he was holding up in the picture. He had the little bullet. It's like, "Hey, do you want this thing as a souvenir?" He's like, "Yep." So we gave him that. I sewed the thing up and then made him promise me that he would get into a clinic in the city if this thing at all got infected in a week. And there was a local nurse that saw him and followed him up, and we gave him some free antibiotics to take as well in case the thing got infected. But yeah, this is one of those things, you get talked into it, but sometimes you really don't want to do that. Next slide, please. This was a 23-year-old woman with nausea and irregular menstrual cycle. She hadn't had a period in 3 months. This was the first bedside ultrasound done in Cabulco. This is Kelsey Drake. She was standing by me at the plane, and somebody put pregnancy, and it's like, bingo, that's exactly what it was. So Kelsey just put the probe on there. It's like, we don't need to do a pregnancy test. Ma'am, here's your baby. And so, of course, the patient was super excited to be able to see her first pregnancy on the ultrasound. She'd been trying to get pregnant for 2 years, and because of her irregular cycle, she didn't know why she was nauseated. It's like, well, you finally got pregnant. So her and her husband were really happy. So it was one of those kind of nice stories. It's like, yeah, you're not sick, you're just pregnant. So she went out with a big smile on her face. Next slide, please. And here was a farmer who came in with GI upset, diarrhea occasionally for the past 3 months. He lost 10 pounds, not trying to lose weight. And he's like, "Doc, something's wrong with my gut." Well, this nice little hospital we're at, we have 2 lab techs there, and these 2 men are like super great to have around. So we got a stool smear from him. We basically just take a little swab, swipe near the anus, get a little stool sample, give it to these guys. They look at it under a microscope. Bingo. This is amoebic dysentery. It's a parasite. So he had Entamoeba histolytica, easily treated with Flagyl by mouth. We put on Flagyl 3 times a day for 2 weeks. And you know, he was super happy. It's like, I'm so tired of having this GI upset and diarrhea and weight loss, and I feel like garbage when I eat. So another one of those things that, you know, we don't see this much in the United States, but it's very common. This town had no potable water. They do not have a city water system, and everybody there knows, hey, the water's probably got bugs in it. So they boil it, but you can imagine sometimes they don't have access to clean water, and they wind up getting parasitic infections. So that's Entamoeba histolytica. It's an amoebic infection in the gut. This is just a picture of the ladies that came to see us when we were there for various complaints. They hand sew these tops, which I thought were absolutely gorgeous. So I made a little collage of them. It's not like us grungy old Americans. We just go down to the hospital in our t-shirt, sweatshirt, whatever. These people were like dressing up to come to see the doctor, and it was just really sweet. And I was impressed with their, you know, artistic ability. I mean, this is really impressive needlework. Just a nice sample. Next slide, please. This was in Guatemala. I'm sure Gil knows exactly where this is. This is in Antigua. And these were 3 residents I took with me a few years ago. We got done with the clinic. We work in that clinic for 4 days, and then we go back, and I tell my chair, you know, we do a day of debriefing. We go over the patients we saw. We look at scientific methods in all these patients on that Friday, and we stay there the day doing that. That's all baloney. We don't do that. We go over to Antigua. It's like, no, if you take people on these global trips and you work like dogs, they will never, ever go back. So we have to take one day and be Joe tourist. And it's interesting, if somebody leaves early and they don't get to do that day, they never, ever go back. That's something the missionaries told me. Is like, if you're bringing nurses and docs, take a day, go have some fun, or those people will never come back. And we need you guys to come back. So we went to Antigua. This is Agua. It erupted, Gil, I want to say like in the 1500s, and water came down and drowned a bunch of people. So that volcano is known as Agua.
That's correct.
Next slide. There's one over the right called Fuego. Is that right? I think so.
Correct.
Fire. And it's still erupting. But anyway, so this is a picture in Guatemala City from the top of the house we stayed at on Friday. Absolutely beautiful city. To me, this is like utopia. The only bad thing about Guatemala City is it's surrounded by volcanoes. Other than that, it's got, I think the San Andreas Fault goes through there and it's surrounded by volcanoes. Other than that, it's absolutely the most beautiful place I've ever been. Just absolutely loved it there. So that night, sun goes down. The old doctor, myself, lays down in the bed. I fall asleep for about 10 minutes. And those three guys I showed you earlier standing by Agua that morning, Justin Evans sticks his head in the room and I'm dead asleep. And I tell you what, if you want somebody to wake you up quick, you have them say to you in a slumber, Dr. Green, I think the volcano is erupting. Next slide. So there's a picture of it from the rooftop through my telephoto lens. So, Gil's probably comfortable with this. Hey, I'm a gringo. I'm not comfortable with hot volcanoes erupting. So fortunately, this thing is like 13 miles away, but still for me, it's like, I would rather it be 1,000 miles away. But yeah, and you can see that little dot down there. That is a giant lava ball that rolled down the mountain. And there are people living down there. So anyway, exciting end of the trip. That's about all it did that night, thank heaven. And you can see the reflection. So we head back to the USA. I think I only got 1 or 2 cases left. Next slide. This is a poor guy riding in his Jeep, and he has sudden eye pain. So, some of you guys have Jeeps. You like to take the top off. You're riding in your Jeep with your leg hanging out. He's flying down the interstate. Something hits him in the eye. He gets a bug in his eye. He thinks, he doesn't know what it is. It hurts so bad he can't even drive. He has to pull over to the side of the road, and he comes into our emergency department. So same old thing, airway, breathing, circulation. What do you see? What do you hear? What do you smell? Nothing really abnormal, but after we do the airway, breathing, circulation, we look at this eye. Something wrong there, right? He's got an abnormal pupil. It's not round. And then there's something wrong with the iris. So that's called iridodialysis. There's a hole actually in the iris, which makes you wonder, did something puncture that? Or was it just like blunt trauma and it tore the iris? So one of the things you learn in your residency is that is a foreign body or a hole in the eyeball until proven otherwise. He's driving in a Jeep and something hits him at 70 miles an hour. He has no idea what it is. So maybe it's a rock, a piece of steel, a bug, who knows? So maybe just a bug that hit him and it tore the iris. So we're going to have to CAT scan that orbit. So we send him over to the CAT scanner, look in the back of the guy's eye at the same time. And it's like, I look in the back of his eye, that is not normal. Something in there. Bingo, here's the CAT scan. So this is basically a slice through this guy's head. You can make out a faint outline of the eyeball. You can even see a little black bubble in that right eye. And that's actually his left eye. But for us, it looks like it's on the right side. So that little black bubble is air. That's not supposed to be there. So something punctured that eyeball and it showed up on the CAT scan. Next slide. This is a little gross, so I apologize for that. This is in the operating room. And If you can go back to that eyeball, yeah, there. The ophthalmologist went in, he put 2 little ports in, that's those little orange things, those are the ports, washes out the eye, sees a piece of metal in there, goes in there and grabs it and pulls it out. That pupil, of course, has been dilated so they can see what's going on in there. All right, next slide. This may be, we're pretty close to the end here, just 1 or 2 more cases, we're done. So you're working in the emergency department one Sunday morning. It's been a very cold Saturday night, and your triage nurse brings you 2 patients. They're both garage attendants. So they worked in a garage overnight, collecting money and sitting in one of those little booths where they collect money. And they come in with their hands with blisters on them. And the temp outside had dropped to 18. So yeah, this is frostbite. People in chat are getting it right. This is frostbite. And if you look at the far left picture, this black gentleman had blood in that blister. So that's a blister filled with blood. That's why it's so dark. The other ones are just filled with fluid. And so the treatment for this, of course, is make sure you warm them up. Never ever let them refreeze. If you think they're going to refreeze because you can't really warm them up, you leave them frozen because you can only warm them up once. And then you warm these up and then just have to basically keep them clean and let them declare themselves to see what tissue is going to turn black and die and what tissue is going to remain pink and heal up. A lot of things have been tried. Thrombolytics, which is an IV injection of a medication to break up blood clots, that's been tried. Topical nitroglycerin, which is a medication that'll dilate the vessels, that's been tried. None of that stuff really seems to work. We don't have a good answer for frostbite treatment right now other than rapid rewarming. So that'll be something for your generation to do research on and figure out, is there a drug that will actually help this and make it better? Next slide. I think this is our last case. So nice lady, 37 years old, presents with a rash for 2 weeks. And it's this fine little red rash all over her back. It's also over her chest, abdomen, upper arms, upper thighs. Started as a little patch on her right thigh. That's gone away, but now it's spread everywhere. Been there for 2 weeks. She's tried a bunch of different drugs, went to one emergency department, and they told her it was eczema. They gave her topical triamcinolone, which is a topical steroid. She said, it hadn't done any good. Doc, I'm going crazy. Either cure my rash or shoot me. This is about to drive me nuts. And that's very typical of this rash. Dr. Fowler noted there was, when I talked about the little patch on her thigh, that's called a Herald patch. And this could be an allergy, but it turns out it's not. If you look at the spots on her back, they're in almost what we call a Christmas tree pattern. So they're little dots and they go down. You can't really appreciate it real well. Underneath the label where it says 37-year-old woman, if you look there, you can see that those are kind of peaked. They're in kind of lines. And so this rash is called Pitteriasis Rosia. And it can start off as a little patch somewhere on the body, and then it spreads. It's thought to be, and this hasn't been proven yet, but when Fowler and I were in medical school, this was totally unknown. Nobody knows what causes this. It's just a rash. We don't know. Nobody knows. And now it's felt to be, this is probably human herpes virus number 7, 6, or 8. And they were infected with it already at some point in their life, probably caused a little fever blister somewhere. That's it. It went away, and this is a reinfection. So it's felt to be a secondary case of a herpetica human herpes virus. And we don't really know how you get it. We don't know if it's sexually transmitted. We don't know if it's oral like COVID. Nobody really knows. But you'll itch for 3 weeks, drives you nuts, and it will usually go away. We now use antivirals for this. So we can put the patient on acyclovir, which is an antiviral, but still not really proven. It's one of these, like, we don't know if that really makes it better, quicker, or not. But that's the general consensus now. Next slide, please. All right, good. That was our last case. I'm trying to make sure we get done here by 9 o'clock. So this was just a picture in a store when we were in Antigua, Guatemala. I loved all the colors. These were just masks that the locals carved. So any questions? Been great. Thanks so much for the questions y'all had and the comments, and for the opportunity to talk to you. Been great. Hope I didn't bore y'all to tears with tales from the past decades. But I did want to try to take you through at least a virtual session so you felt like you were going in emergency department rooms and seeing kind of the wide variation that we see in emergency medicine. So
let's everybody put a good warm thank you to Dr. Green into chat. Looks like they're boiling through.
Yeah.
Walt, you've still got about 700 people who are hanging on every word. Elena, do you have some questions for Dr. Green?
Yes, we do. We have a lot. So one of the questions says, what was it like traveling to a country to treat people where English isn't the primary language?
Yeah, so it's definitely a challenge. And you know, I already mentioned, we always make sure we have a local physician or several with us because the cultures can be so different. And then the hardest thing is finding translators who actually are good in medical translation. Because as Gil can tell you, we have a lot of people that speak English and Spanish, but they'll come in with their family and they literally don't know the names of body parts in both languages. They like, I know that name in one language, but I can't translate it. And they may know it in English or they may know it in Spanish, but they don't know it in both. And that was a huge problem in Russia because the communists did not, we did not meld well. The capitalists and the communists did not meld well between 1917 and 1993. And so for the first literally 3 days in clinic, everybody I saw, it seemed like, had seizures. It's like, why do all the Russians have seizures? They were all telling me they had seizures. And it turned out that the translation for muscle cramp in the Russian English dictionary that they had was seizure, not muscle cramp. So finally, I had a Russian medical student who showed up and she spoke some English and she figured out what the problem was. She said, this is not seizures. They're describing muscle cramps. It's like, okay. So it could be very tough, but the key is finding a good translator and making sure you have good local docs with you.
Do you have the same translator the whole time, or does it just switch?
Yeah, we switch translators a lot of times. Sometimes we don't. It just kind of depends on your situation. When I was in Central America, usually we would latch on to just one translator because they could figure things out. And a lot of them were actually learning medical English. And so they spoke Spanish and English very well, but they're like, I need to learn all the parts of the GU system. So like, I don't know how you say bladder. I don't know how you say uterus. I don't know say how, ovary, testicle. And so part of it is once you kind of get that relationship going, then, you know, they're learning, I'm learning, and we're working through the patients at the same time. So it can vary, but we in general held on to the same translator.
Okay. Another question we have is, does medical school prepare you for all these medical terminology, diseases, and conditions? In other words, how do you accumulate all the medical conditions to diagnose?
Yeah, so each year of med school is a little bit different. And just to try to shorten it, the first year is learning normal human physiology and all the normal parts. Second year is learning all the diseases. So third year then is going on to the clinics. You know what the normal is, you know what the diseases are, but you've never seen it in a patient. So third year, you're introduced to the physical examination. You've kind of got the terminology. You don't have a clue what you're doing. and you learn the physical exam. And then the fourth year is learning exactly what lab, what imaging you have to apply to help your diagnosis. So when you get out of medical school, you've got the basics, but you're really not a real live doctor still. That's what the residency is for. So your residency is where you actually put all of that together and your treatment plan, and you figure out how to then go on down the road. So each year has a little bit different emphasis. We try to make every year have all the parts to it, but the reality is I can't teach you about disease until you know what the normals are. So that's it in a nutshell. So you learn most of that in med school, but all the fine tuning is done in residency. And then, our joke is, 5 years out of residency, you'll begin to feel like you know what's going on. So it is a very long, humbling process.
All right. Another question we have is, do physicians have to join a group like Doctors Without Borders to participate in global health? How does this work?
Yeah, absolutely not. And Doctors Without Borders is a great group, but your minimum time there is 6 months. So if you join them, you're committing with them for 6 months. Well, there's absolutely no way I'm going somewhere for 6 months. I've got too many other responsibilities. And some people do that, more power to them. We have several residents who graduate. Some of them go directly into a mission field. They're like, my place, I don't know how I know this, but my place is in Guyana, and I'm going there, and I'm going to practice medicine there. I'm going to Kenya. I'm going to Nepal. We've had several residents do that very thing. And that's part of their faith. They choose to do that. The groups I've been involved with have just been a couple of weeks. And that's what I try to get our residents to do, is do this for a week at a time and give them a taste for it so they can, hopefully commit to that later in their career. So they can donate a week here, a couple of weeks there, to these other countries.
Okay. Another question is, what are some ways or examples the healthcare staff practice cultural competency in high stress situations?
That's probably about a 2-week lecture. So it is also a learning process, and it can be embarrassing. You make mistakes. I think one of the things you have to do with cultural competency is just be humble and realize, I'm gonna bump into a lot of people. They don't believe what I believe, and so it can be a little odd. And we're very close to a huge international airport, and we get patients all the time directly off of a plane from another country. And here in the U.S., for example, we believe in telling the patient, hey, you've got a pretty big mass in your right lung. That probably is a cancer. This is a really bad diagnosis. You need to get your family together. There are a lot of cultures that don't believe that. The Russians, for example, don't believe that. They believe the state should carry the burden of a terminal disease, and you don't let the patient know that. So part of it is your own education. You have to figure out what is the practice in that culture, in that country. And sometimes that country comes to your doorstep in your emergency department here in the US. So I think it's something that's tough to deal with, and you just have to be humble and open to it. I think that's the best I can answer it in a short time anyway.
All right. I will do one more question, and the last one is, what is your take on the new vaccines that have been developed for COVID?
Yeah, excellent question. Probably the same take as you guys. It's like, I hope it works. I hope the side effects aren't that bad. And I wish we could have 10 million other people take it before I take it. But, all of us are going to be front line. We're going to be hit up pretty quick to take this vaccine. And, it's kind of a easy decision for people like myself. It's like, I've seen people very, very sick with this disease. It's ugly. So if I'm given the opportunity to take a vaccine that is considered to be safe by the FDA, I'm going to take it. I'm not so humble, or I'm not so egotistical to say, oh, it's not going to cause me any problems. It might. I might have some pretty bad side effects from it. I've had a gazillion vaccines in my life, and knock on wood, I've never had a bad problem from one of them. I think the worst I ever had was yellow fever. That was a nasty vaccine. Made me feel lousy for several days, but like the flu vaccine, doesn't ever seem to bother me. Tetanus, diphtheria, all that. So my plan is, if I get offered to take it, I'll take it, and pray for the best result. Whatever happens, happens. But I'm hopeful, like all the other Americans, that we'll have a good vaccine. It'll be safe, and we'll get back to normal. But we'll see.
I think that's I think that's really well said, Walt. An article I read today was talking about some of the side effects of what folks had from taking, especially the second dose of the Pfizer vaccine and the Moderna vaccines, aches, pains, and very flu-like stuff. So we've got a whole lot more to find out. Walter Green, what a wonderful discussion we had tonight. You presented indeed the breadth of emergency medicine across borders, and what we heard tonight was so emblematic of the love and humanity that you have for so many. Let's everybody put a great thank you to Dr. Green into chat, please. A person contacted us and said, would love to chat with you about some of the opportunities about working overseas, and just contact Virtual Shadowing and we'll put them in touch. Walt, thank you so much. What a great discussion. We're so humbled by what you presented tonight. So again, thank you so much. We've had 32,500 people sign up on the website so far, Walt, and all of our team. And we're just so heartwarmed by the great reception that we've seen across the country and around the world. Over 800 universities represented worldwide. We're so excited at what Gil Salazar is doing as far as virtual observation. And we certainly look forward to this program merging into Gil's efforts so that we can be of great service to those seeking out a career in medicine. Elena, thank you for being such a charming host tonight. We so very much appreciate it. Ladies and gentlemen, we've had 2 wonderful hours. Thank you for joining us tonight. We look forward to seeing you next week for yet another terrific presentation. Now, Elena, do you need to cover some of the quest base just for a moment?
I know Reagan does. She was going to touch on that.
All right, Reagan, would you take it away, please?
Sure. Can y'all see the new quest-based format slide?
Yes, ma'am.
Beautiful. Okay, so I'm just going to quickly cover the new format, and I want to go into great detail so there's no questions about it. So after you type in the PIN and password, this blank slide with just this instructional information is going to be on the first page. Please read through this and make sure that you follow all the instructions so that you can take the assessment, it gets recorded, and you can get your certificate and everything's great. And then as you can see, there is a next button. So you won't see the quiz questions on this slide anymore. You're going to have to push next to progress through the quiz. So the next page is going to be the personal info slide. And this is required to take our assessments in order to have your assessment recorded. And so please fill out your first, last name and your email. And then after that, you'll need to hit next again. And after that, you'll enter into the quiz. So go ahead and take the first question, select your answer, and then you'll continue to hit next until you go to the very last question. And so once you're at the last question, the next button will be changed to a submit button. And so you will hit submit to have your quiz graded and recorded in our system. And then finally on the results page, there will be directions. Please download your certificate. It'll show your score, the name that was recorded, the email that was recorded. And as you can see, circled in red is the link to your certificate. And if you took it on a desktop or a laptop, you should be able to download it immediately. However, if you took it on a mobile device, you may not have access to it. You do have 2 attempts. So if you took it on a mobile device on accident the first time, go ahead and retake it on a desktop or laptop to download your certificate. And just a few last minute things. You don't have to send your certificate to us. We have it already in our records once you hit submit. If you have any trouble accessing the assessments, please just email us at virtualshadowing.com or virtualshadowing@gmail.com. And then after the due date, there's nothing we can do to reopen it. So make sure that you email us before that final due date. And the next slide is the quest-based info, and that quiz is not up yet. It will be posted about 15 to 20 minutes after this session has ended, and this recording will be posted on YouTube tonight. So here it is. And thank you so much for attending. And Dr. Green, thank you so much for having such a wonderful presentation for us.
Yep, thanks for having me. Much appreciated.
Do they need to write this pin down real quickly, Reagan?
Nope, it'll be posted to our website, our Instagram, and this recording will be posted to YouTube tonight with this information at the end.
Well, once again, everyone, what a wonderful session. We look forward to seeing you next week for our next, we have a whole bunch of a series of sessions coming up that I think you're really going to enjoy. Have a great Thanksgiving, have a great holiday, and everyone be safe, wear your mask, keep your distance, wash your hands. Let's get this epidemic out of here. On behalf of the whole virtual shadowing team and Dr. Green, our presenter this evening, we wish you a terrific evening and have a good night. Bye-bye.
Thank you, Walt. Really appreciate it.